More than a year ago, some of us involved in active surveillance support met to discuss programming for 2022. The idea was to try and avoid program duplication through cooperation among support groups. We all agreed that we weren't connecting as much as we should with newly diagnosed men or with men in the gray zone, PSAs of 4 to 10, who had not yet been diagnosed. We thought it would be a good idea to develop a series of videos which cover the basics for men and their partners who may be anxious or worried about what was happening to them with no support immediately available. The videos would be a catch-all group of webinars that would answer the many questions a recently diagnosed man might have, all in one place without having to scour the internet. A working group called the Active Surveillance Coalition was formed to develop this series of programs under the name Active Surveillance 101, an introduction or a basic course in active surveillance. The vision was to have real patients and their partners simulate visits with top experts in the field and cover essential questions. Today's video is with Justin Lorentz of Sunnybrook Hospital in Toronto, Canada. Justin is a certified genetic counselor through the American Board of Genetic Counseling. He practices clinically out of Sunnybrook Odette Cancer Center in Toronto in their cancer genetics and high-risk program. He is also the lead of the Male Oncology Research and Education Program, a registry for men with hereditary cancer, as well as a consultant on the well-advertised PROMISE study. His current academic interests are in hereditary cancer, with a focus on male breast cancer and prostate cancer genetics. The video also features Larry and Nancy White, a couple from New Mexico who have been through this themselves and are our model team. Our programs deliberately avoid the PowerPoint slides usually shown in these type of webinars in order to replicate as much as possible what a real counseling visit is like. The Active Surveillance Coalition includes Active Surveillance Patients International, ASFI, the Active Surveillance Virtual Group from ANCAN, Prostate Cancer Support Canada's nationwide Active Surveillance Virtual Support Group, Prostate Cancer Research Institute, PCRI, and the Active Surveyor Newsletter.
Hi, Larry and Nancy. How you doing?
We're doing great.
Great.
Good. My name's Justin. I'm a genetic counselor, and I want to spend a little bit of time talking to you today about genetics and how that applies to you. It's a bit of a sci-fi topic, and I want to explain what this means clinically nowadays.
Well, it's very nice to meet you. Nancy and I are on this journey together. I hope you appreciate that. We're trying to do everything as a family here, since whether or not I have cancer or not, or any genetic problems, impacts all of us. Nancy has done a great deal of research on my behalf and has helped tremendously down this path.
So it's really nice to meet you. And we've written down a few questions, but we're really very unfamiliar with genetics. So I wonder if you'd allow us to record this session today.
Yeah, absolutely.
Okay, great.
I was diagnosed with prostate cancer, Gleason 6, recently. And I think I even read that some people don't even consider Gleason 6 to even be prostate cancer, but in any event, our urologist recommended that we see a genetic counselor to see if there's other testing that might be done to help us better decide about our active surveillance situation. It seems that there are other criteria that we might look at that you can probably help us with to better solidify that discussion, because right now we are on a path of active surveillance. And again, Nancy's done lots of research, but this is a fairly a complex and confusing issue that we found to be difficult to sort out. So we're looking forward to hearing from you.
Yep. No, very good.
So Larry's 70, and his dad
I wasn't going to say that.
died. He died from prostate. his dad died from prostate cancer at 74. So naturally, we've wondered for some time if he has inherited a risk of prostate cancer from his dad. And we're also concerned about our children, so that they might learn if they could possibly have some sort of inherited risk factor. And the urologist mentioned something about BRCA1 and BRCA2 genes being important. And are there others as well? Anyway, so we have a lot to learn.
Yeah, no, I think that these are all great concerns, questions, and when we go down this journey of cancer, we're opening ourselves up to a lot of terms and thought processes that we never anticipated we'd need to know about, and so I can understand how there can be questions and wanting to get as much information that we can to make the best decisions that we can. Let me start off with talking just a little bit about genetics, and how genetics applies to cancer in general, prostate cancer specifically, and when it comes to perhaps decision making, or how it can apply to active surveillance, and then how it can apply to other family members. So let's start with the genetics piece right off the bat. So all people are made up when there are eggs and a sperm that fertilizes the egg. That's how we get the genetic information that makes a person a person. We get half of our genes from mom's egg, we get the other half of our genes from dad's sperm. And we have about 20,000 genes that make a human a human. Our genes are almost always working just fine for healthy adults. And sometimes there are mistakes or mutations that we have inherited from mom or from dad that can cause medical problems. Now, if we're focusing on the world of cancer genetics, there are some genes that protect us from cancer, and we want these genes to be working perfect. Some people are born with a mistake or a mutation in one copy of those genes, maybe the copy they inherited from mom's egg, maybe the copy they inherited from dad's sperm. And if people do have these inherited gene mutations, means that these genes that protect from cancer can't do their job as well. People are predisposed to getting certain cancers. Mm-hmm. All cancer is genetic. All cancer occurs when a healthy cell accumulates mistakes or mutations, either through exposure to the environment. Think about a skin cell. When we get a sunburn where it's radiation that's hitting our skin, it's causing DNA damage, and our body removes that, and our skin comes off sometimes through a burn. Sometimes these mutations can happen more subtly, and our cells accumulate mutations that then get repaired by repair mechanisms that we have in our cells, but the process is imperfect. It's 99.999% accurate, but that 0.001% is enough sometimes for these healthy cells to accumulate mutations throughout someone's lifetime. If we get the right mutations in the right genes, it can lead that cell to go down this trajectory of becoming cancerous. And really, a cancer cell is just a healthy cell that's started to go rogue, divide uncontrollably, take up resources around it. And this process of mutations that can accumulate within just that cluster of cells that eventually turn into a tumor. And so there's an important difference in that. When we say that all cancer is genetic, it doesn't mean that we're all born with genetic predispositions. It means that the cancer itself has lots of gene mutations. And that information can actually be really insightful for doctors. There's some doctors who want to take a sample of your prostate tissue or cancer tissue in order to learn more about the cancer to better treat it. That's a type of genetic testing. It's called somatic testing or tissue testing, where we just look at the tissue itself to see if there's a mutation. Mm. Whenever we do testing of the tumor itself, we're just looking at the DNA present in that tumor or that cancer. If we were to take a sample of the tissue, the healthy tissue right next to it, the DNA inside of both these tissues would be very different. The cancer DNA would have lots of different mutations in it that made that tissue cancerous. And the healthy tissue next to it would probably have very few mutations, expectedly no mutations. And that's the healthy tissue. But there are some people who were born with a gene mutation that they inherited from mom or from dad that may have helped expedite this process. And these people have what's called a hereditary cancer syndrome or predisposition to certain cancers. And so that's what another type of genetic testing can identify, and that's called germline genetic testing. Germ comes from, the fancy scientific word for meaning a cell like an egg or a sperm, where we inherit these genes from. And if we do germline testing, whether we use a saliva sample or a blood sample, doesn't matter. All we're looking at is some type of tissue sample to see, are there any mutations in these cells? And are these the cells that we inherited from mom or from dad? Any questions about that?
Well, I was wondering why the sample of that's sent for somatic, why can't that sample also be used for genetic?
Yeah, it's a good question. And so if we do send a sample for somatic testing, we will see that germline mutation there. We're going to see all this other noise of all these other mutations.
Oh, okay.
And so what we could do is we could sample the tissue itself, and we say, okay, well, this is what mutations are present in the cancerous tissue. And then we say, let's also do a germline, and we'll spit into a tube or take a blood sample, and we can compare. If the germline's negative and there's lots of mutations in the somatic, we say, okay, well, these are the mutations that we're working with for this cancer. But some people have lots of mutations in the somatic. That's always going to be the case. And they also have a mutation that's present in all of their saliva cells or blood cells, and they say, oh yeah, there's a germline mutation and there's all these mutations in the tissue. So you can have both, or you can have one or the other.
Okay, gotcha.
Well, so in my situation, where I'm a Gleason 6, I mean, I understand the BRCA1, BRCA2, if it can impact my son or daughter. Or impact my treatment. It might need to be more aggressive, I guess. But are there other testing that you think of or that one might take to better inform a person doing active surveillance?
Yeah, and
I mean, that's the thing I'm not sure about. I don't even know if I really have cancer by some people's definition, and yet we're talking about genetic counseling.
Yeah. And so, genetic counselors typically live in the world where we focus on the germline stuff, where it's focusing on the genes that we have inherited from mom or from dad. And so that's usually that blood test or that saliva test that can give us insight to, hey, was I genetically predisposed to get this cancer that I have now? And you mentioned the genes BRCA1 and BRCA2. Those are two very important genes in anybody's prostate cancer story. Most people don't have mutations in these genes. Most people's BRCA1 genes and BRCA2 genes are working just fine. The impact of these gene mutations that we've inherited on something like active surveillance, for example, has been somewhat studied, but maybe not well studied enough. It's difficult for us to make clinical decisions based on someone's status of BRCA1 or BRCA2. And there's another gene out there, it's called ATM. And the reason why I'm picking on these three genes is because there was a study that was done, I'm going to say 2019, that analyzed 1,200 men who were on active surveillance and looked at their genes, BRCA1, BRCA2, ATM. And they said, okay, listen, for the men who have these mutations, how likely are they to reclassify on active surveillance? And what that means is if they are Gleason 6, what's the chance of them moving up to Gleason 7, given that they have these G mutations? And one thing that was interesting in that study is they found that men with BRCA2 mutations were more likely to reclassify. In fact, they found that people with all three of these mutations were more likely to reclassify, but the bulk of that was men with BRCA2 mutations. So for some people, they may say, hey, well, if I have a BRCA2 mutation and I go on active surveillance and this study says I'm more likely to reclassify, should that be a thing that I should be talking to my doctor about? And maybe we should be thinking more about other strategies. Or if I do choose active surveillance, maybe my active surveillance protocol is a little bit different from guys who don't have the BRCA2 gene mutation. So this is another piece of information that we can use to inform our care. There's lots of genes that can be tested for that are associated with prostate cancer that we know of now. We picked on those three, but there's plenty of genes. And these genes aren't usually just prostate cancer genes. They're usually genes that increase risk for a bunch of different cancers. Sometimes it is just prostate cancer, but sometimes it's prostate cancer and colon cancer, or prostate cancer and breast cancer in both men and women. Sometimes it's increases risk for, the genes can increase risk for ovarian cancer. And so this could be something that has implications not only for an individual and their current risk of prostate or their current prostate cancer management, but also potentially other cancers that that man may be at risk for, as well as if it is a germline mutation and he inherited his genes from his parents, well, there's a chance he could pass that gene on to his kids. and they could be at elevated risk for cancers as well.
What kind of test do you recommend him taking?
Yeah, so I think that doing genetic testing to understand your germline status is important. It's an important piece to understanding the kind of puzzle of what we should be doing going forward. Insurance companies may be able to cover some aspects of genetic testing. Sometimes genetic testing can be paid for out of pocket. With different companies that are out there. There are also clinical trials that are available that would offer genetic testing as being involved in the clinical trial. One such one is the PROMISE registry, where any man with prostate cancer is eligible for participation in that trial and gets germline genetic testing as part of that. If insurance doesn't cover it, there's other options to pay out of pocket or to be involved in clinical trials. And then getting this genetic information is something that healthcare providers can sometimes use to help inform medical decisions.
We have done some YouTube work, okay?
Okay.
So I'm sure nobody does that, but
it's great.
Yeah, or not, maybe, I don't know. But Nancy, did you look at a couple of things that you were wondering about, different types of tests?
Well, the Oncotype DX,
Yep.
but that's somatic, right? And
Yep.
The Decipher again. Somatic. Do you think that Larry should do those as well, or just go straight to the genetic PROMISE?
Yeah, it's a great question, and I think that those are decisions that you make with your oncologist, and they can help facilitate those types of tests for you. Again, if it's another piece of information that could be useful in your management, if your Oncotype DX comes back and shows that your prostate cancer looks genetically like it's not as aggressive, that might be useful information. But that moves into that territory of treatment decision makings that oncologists like to use, and typically those healthcare providers are the ones who would help facilitate that type of somatic or tissue testing.
Okay, so as far as accessing the genetic testing, where's the best way to access, for example, the PROMISE study?
Yeah, so the PROMISE study.
Should I just Google it?
Yeah, exactly. So Prostate Cancer PROMISE is the website for that. But if you just Google prostate PROMISE study, it'll pop right up there.
Okay.
And enrolling in this registry, and basically a registry is just a collection of individuals who have something in common, and in this case, it's men who have prostate cancer. As part of that registration process, you sign up for genetic testing, and they send a saliva kit to your home. You spit into a tube, mail that saliva kit back off. That facilitates the genetic testing, and then when we get the results back, you have the opportunity to talk with the genetic counselor about your results.
So that would be you, right? I mean, we would be possibly getting this done to you, coming back to you to go over our results of the testing.
Exactly. And so
that's whatever testing you suggest that we should probably do, to help in our decision making.
Yeah,
right?
Yeah. And so a lot of these tests, are focused on certain types of cancer. So it could be a cancer gene panel or just a regular hereditary gene panel. With the PROMISE study, it's a panel of looking at cancer-related genes. There's 29 of them, and they cover all the known prostate cancer-related genes. And whenever anybody does a test like this, there's different types of results that we can get back. And so sometimes we talk about what's called anticipatory counseling, so that we know what people are signing up for when they do a genetic test like this. And when someone does do a test like this, we can get different types of results, and some of the language that's used in the results can be a little bit confusing. I have been using the word mutations or mistakes to describe changes in genes that can cause problems, but really what they're called are variants in genes. And there's multiple different types of variants. Most variants are benign, which means that they're not problematic. And those variants are typically not reported. But if we do find variants that are problematic, and we call those pathogenic variants, those are gene mutations or changes that are medically significant, and that could change someone's care. And we know that a pathogenic variant could be problematic and cause the gene not to work as well, and cause downstream cause a downstream condition.
So what percentage of patients that you test or that are tested, do you know what percentage are found to have a significant marker?
Yeah, so it really varies based on the type of prostate cancer that an individual has. It also varies based on something like family history. So Larry, you described having a father who has prostate cancer, who had prostate cancer in his 70s. And with that family history, having two individuals who were diagnosed with prostate cancer after the age of 60, the risk of having a gene mutation actually isn't super high. And that's a gene mutation in one of these known genes. If someone was diagnosed with a metastatic prostate cancer, a prostate cancer that spread to other parts of the body, there's about a 12% chance that they have a gene mutation that may have predisposed them to that type of cancer. So there's different factors that we take into play that can help us estimate someone's risk of having a gene mutation or a pathogenic variant.
I'm also curious about what other aspects of my family history that might be important that we look at.
When it comes to family history, genetic counselors like to get as much information as we can, not only about prostate cancer and ages of diagnosis, but also about other connected cancers, like if there's a family history of breast cancer or ovarian cancer, pancreatic cancer, colon cancer. This could maybe increase or decrease my assessment about what the chances are of finding a germline mutation. And so if the family history is just prostate cancer and age of onset is not what we consider to be early, such as over the age of 60, the chances of us finding a known gene mutation that's kind of on our radar today is not very high, maybe about 5% chance. If I can kind of extrapolate a little bit on some of the data that's out there. But if there was, for example, a family history of ovarian cancer, which is a lot more rare, regardless of the age at which someone was diagnosed, then the probability might be a little bit higher.
Well, in terms of my family history and even extended family history, the only cancer that I know that in my family was my dad's prostate cancer. So otherwise, although being 70 at the time that other people might have had cancer, I mean, it might not have been diagnosed. I mean, it just wasn't. In fact, my dad's diagnosis and whether or not he had metastatic disease and that sort of thing was not well understood either. So I think that's one of the reasons why we're also curious about the genetic setting too. But I think you've answered many of our questions. We may have some more, but so right now we should do the testing that you recommended and the promise. And then get back together, or how long does it take? Or
it can take maybe around 4 weeks, sometimes up to 6 weeks to get a result back from a genetic test. That's usually from the time that a sample is sent out. It can vary from lab to lab. And then when results get back, there'll either be a prompt for you to speak with a genetic counselor. Sometimes it's something that's encouraged, and sometimes it's something that if the result is positive and shows something that's meaningful, there might be more steps to take to communicate those results.
If it comes back, I mean, will my urologist get a copy of this, or will you or someone else be talking to my urologist to let him know, or is that something that we're supposed to do? Or?
It typically depends upon who is ordering the testing. Sometimes if a urologist is ordering the testing, it'll go back to them. If you are ordering the testing yourself, then it'll go back to you. And it's always something that you can share with whichever healthcare provider you want. And yeah, so a urologist and oncologist always be really a useful people to have access to this information.
All right. Well, thank you very much.
Thank you so much.
No problem.
We appreciate all the information. It's excellent. Thank you.
Thanks to all our participants in today's webinar. Thanks also to Alex and Peter Schultz of PCRI, who have made the resources of PCRI available to the Active Surveillance Coalition in helping to produce and edit these webinars. Please stay tuned to further webinars in the AS101 series. Thank you.